Thank you very much. I was very excited when I was invited to speak here to represent the father. So just as background, I'm a urologist. I specialize in male reproduction. And I think we've heard here, appropriately, a lot of focus on the mother, but I want to make sure that we don't forget the father because we certainly play a role. I always tell my couples that fertility is a team sport. So these are my disclosures. These are kind of some men's health companies, none of which will be relevant. And I want to start, this is a low resolution, just kind of talk of sort of the outline of the talk. We're going to start at the very beginning at sperm, and then we'll go all the way through to some birth outcomes as well and the offspring. And I don't know if anybody saw this provocative Newsweek issue that came out last year, Who's Killing America's Sperm? And We Can't Blame It on Trump, or can we? I'm not going to go into politics. But this was based on this study. This was a landmark study that came out last year, or I guess 2 years ago now, that showed this decline in sperm quality really all over the world, mostly in the Western world, over the past about 40 years. And we're not going to go into etiology, but I guess the question is, why is this relevant? And I think it's relevant from data like this. So this is data out of Denmark. This is a prospective study, about 400 couples, and they were followed for pregnancy. And so what they did is looked at semen quality in men just to see how likely they are to get pregnant every month. So first we'll look at sperm concentration here, and then on the x-axis is concentration. This is the percentage of couples that were pregnant per cycle. You can see as sperm quality increases, it certainly plateaus, but the better semen quality, the better sperm concentration here, the more likely to get pregnant. And you can see that for motility. This is kind of presented in a funny way. This is non-motile sperm. So as we go left to right, this motility goes down, but you can see the same sort of trend here, lower motility, lower chance of pregnancy, and then the reverse way, more normal morphology or shape of the sperm, more likely to get pregnant. So couples always ask me, let's say I'm here, how can I get further up there? And so how can we improve sperm quality? So there's a lot of ways that we can potentially do it. One way that I like to focus on is health, and there certainly is kind of reciprocal relationship between a man's reproductive and somatic health. And this really elegant study was done in Milan a number of years ago, where they asked a very simple question: are infertile men then less healthy than fertile men? And this was done in prospective fashion. Infertile couples that came into the clinic were all categorized and charted, and they recruited a fertile cohort as well, and they just compared the health between these infertile men and fertile men. And they compared health using something called the Charlson Comorbidity Score. I'm sure a lot of people in here are familiar with it. Basically, it's sort of a metric for health. So every different comorbidity is given a score, and then they're summed at the end, and so you get a composite score. And just like golf, lower score is better. So you want a score of 0, ideally. And these are reproductive age men, in their 20s, 30s, and 40s, so you'd expect them to be very healthy. And for the fertile men, that's what you see. So in the fertile column, you can see that about 90% of these men have a Charlson Comorbidity Score of 0, so they're very healthy. But when we look at the infertile men, we see a little difference here. Here, only about 75 or 80% of these men are totally healthy. So we're seeing these differences between fertile and infertile men, certainly in ability to conceive, but also in health as well. And if we look at this sort of a little further on, here we're looking at Charlson Comorbidity Score. These are the different columns. And then we're looking at sort of different measures of testicular function. So we can see FSH, which is a gonadotropin. It stimulates in a man spermatogenesis or sperm production. And as Charlson Comorbidity Score increases, the FSH, you can see that here, also increases. So it's suggesting that this hormone has to do a little bit more to get sperm production to go, because the testicles are not functioning as well. There's sort of a feedback loop involved there. Testosterone levels also a little bit lower for less healthy men. And then we look at all the different sperm parameters: volume, concentration, motility, morphology, all a little bit lower for the less healthy men. Again, so there's this relationship between health and sperm production here. So then based on that, right, if you look at this picture, you would expect that the man on the left should be more likely to have a healthy baby, right? He's eating well, younger, thinner. But is there data to support that? So we looked at our IVF data to ask that very question. So we looked at men's different comorbidities and just saw how they did in their IVF outcomes. So we looked at FR, which is fertilization rate, pregnancy rate, implantation rate, live birth rate. So we looked at a lot of things. Certainly multiple comparisons will be at play here, but let's look at the diseases of the nervous system. So for men that didn't have diseases of the nervous system, a 23% live birth rate compared to those that did, about a 15% live birth rate. So there are a few of these patterns that we saw. These men that had these certain comorbidities, and we don't know if it's the disease, maybe it's a treatment that we offer these men for this disease, but we did see some differences for IVF successes. And then even when we looked further, now we're looking at actually the baby itself. So we can look at birth weight, gestational age, those are easy for us to characterize. So for men that had diseases of the endocrine system, so lower birth weight, for example, and then genitourinary diseases, men with that diagnosis. Their children tended to be born at an earlier gestational age. So potentially a man's health may impact the next generation. So now I want to kind of shift gears to I think the best studied male risk factor, and that would be age. So I put this up here not to talk about the monarchy, right, or get into the Meghan versus Kate debates. I don't know where everybody stands. But just that everybody knows that there's this huge demographic change that's going on regarding age. Mothers' ages are going up, fathers' ages are going up, and that's really well studied and known. And we know in this country because all births are tracked, it's all collected by the CDC, and they publish reports every year. So this is an example of one of the reports that came out a few years ago, looking at about 30 years, from 1970 to 2000. And you can see the births for mothers, or the age of mothers at births is increasing for both the first birth, all births. See that steady increase. And then they did a more recent update in 2016, and they showed the same pattern. Even over the last 15 years, we see the steady increase in how old a mother is at the time of birth. And so when this came out, there really is not a lot of data on men. I don't know if any of you have tried to find this. So I actually emailed this group, TJ and Brady, and I said, as a reproductive urologist, this data would be great for men too. We talk about this all the time. And they said, well, we don't really have the bandwidth to look at it, but this data is publicly available, so you're welcome to do it. So we did. So this is that data. This is really kind of led by Yash Khandwala, who's now one of our residents. He took a year to do research and really did a fabulous job. But what this does is show about 170 million births, right, from the 70s to most recently in 2015, that the age of the father has increased about 3.5 years. So about 1 year for every decade, we're seeing fathers get older and older. So it's hard to see here, but there's a gray line here that shows the overall trend. Now it's stratified here by race, and we see this across all race ethnicity, this increasing age of fathers. Now it's important to know when we look at this data that not all fathers are actually reported on a birth certificate, only about 88%, and it does vary by race, ethnicity, education, you'd expect of the mother. But we have it for a lot, and it's also actually interesting, I don't know how many know that on a birth certificate, about 4% of the fathers are actually misrepresented. So it's actually fairly common. I could tell you lots of stories. And so why is that important? Well, if we just look, let's say, what's an older father? Well, I think there's no universal definition, but if we just pick some random numbers, 40, 45, 50, let's just look at how these changes have occurred over the last 40 years. So over the age of 40, in the 70s, about 4% of births were to men over the age of 40. Now it's about 9%. All right? How about over age 50? So in the 70s, about 0.5%. Now it's about 1%. So if there's 4 million births, there's 40,000 children that are born to fathers over age 50. And so the question is, what are the implications of that? So we know that there are certainly some diseases associated with older fathers. So achondroplasia or dwarfism was one of the first diseases identified like that. So this was taught us about 100 years ago. And it was noted that this dwarfism tended to be more common in last-born children, the couples. And so eventually they looked at paternal age, and eventually they figured out that it actually tracked more with the father. Here, so you can see the population risk about 1 in 15,000, so it's relatively uncommon. But if you look at fathers over age 50, that risk goes up tenfold. So it's pretty profound. So we'll come back to these paternally inherited diseases. But first, let's look at some more kind of proximal measures. So first, we want to look at stillbirth. This is data from Jonathan Mayo and Gary Shaw. So this is we're looking here at maternal age. And I think it's certainly no surprise that as a mother's age increases, the risk of stillbirth increases. But there's actually some risk associated for older fathers as well. It's sort of this J-shaped pattern that Gary talked about before. But as fathers get older and older, the risk of stillbirth does increase in that age group as well. Now, how about if we look at some other birth outcomes? So what we did here is we looked at the last decade, so about 40 million births in the United States. And we just looked at some outcomes that are available through birth certificates. So first we look at gestational age, birth weight, APGAR score. So the different rows represent paternal age, and then our columns are the different outcomes. What we can see is that gestational age tends to be earlier for older fathers, birth weight tends to be lower, older fathers, and APGAR score tends to go down. And then when we categorize these different variables, we see kind of the same pattern, more likely to have premature births, low birth weight, low APGAR score. So hopefully with this kind of data can make it to Gary's slide, maybe the next time you give that talk, is an established risk factor. Other things too, assisted ventilation, neonatal intensive care unit stay, antibiotic use. We see a higher risk for older fathers. Seizures, and then when we just did a composite of all these sort of adverse things that we're looking at, we see this higher risk. Now one thing that you kind of may be thinking and asking is that, or that you may know, is that maternal and paternal ages track very closely together. How can you control for that? Sometimes it's not that easy just to put it in the model. So one way that we try to do it is by stratifying. So we looked at different strata of maternal age to see whether the same patterns existed, and we saw the same basic trend, whether the mothers were kind of younger, under 25, 20s to 30s, or over 34. We see the same pattern, older fathers tend to have this higher risk. Here, this is our composite risk of any adverse event at birth. So those are the offspring, but how about the mother? All right, so we're gonna look at some outcomes for the mother as well, again, because it's a team sport. So we looked at gestational diabetes, gestational hypertension, eclampsia. These are outcomes that we were able to track through birth certificates. And interestingly, what we saw is this higher risk of gestational diabetes to older fathers. We didn't see it for hypertension or eclampsia, but for mothers who had an older partner, so you can see for the oldest group, a 30% higher risk of gestational diabetes. So why that is not known. There's certainly, you can posit some things. We've heard about the placenta, so that's a possibility, a possible mechanism. But certainly it's, this is borne out of about 40 million births here in the United States. So now let's come back to some of these other, I call sort of specific paternal age effects. So advanced paternal age is associated with new mutations in the genome, and this risk increases linearly for some mutations and exponentially for others. So there's certain diseases that are associated with paternal age. So we heard about achondroplasia, but there's lots of others, Apair, Cruzon, Pfeiffer. And actually when you look at these, a lot of the mutations, a lot of the specific genes are known. So here are fibroblast growth factor receptors. It's about a 1 in 30,000 births for those, and then there's some others, the RET gene, HRAS gene. These are all proliferation pathways where these are seen that lead to these disorders. And what's interesting is when you look at the sperm of men, these mutations are more likely to accumulate in older fathers. So this is for Apair disease. So here we're looking at paternal age, and these are two of the mutations that cause that disorder, and you're more likely to see these mutations in the sperm for older fathers. So why is that? Well, this study shows that as we age, as men age, we accumulate mutations in our germline. And this is done through several families. And what they're able to show is that in general, as a man ages, he accumulates probably about 2 mutations in his germline every year. So if you can kind of hypothesize a man who's 40 has about 20 more mutations than a man who's 30. And obviously we have billions of base pairs of disease, so likely that's not going to make too much of a difference. But on a population level, again, if we're seeing this doubling in rates of 40-year-olds compared to where we had 40 years ago that were having kids, maybe some of these may become consequential. And so let's just take a brief moment to review spermatogenesis. I'm sure many people do know it, but I probably think about it more than most in this room, I would imagine. So we have our spermatogonia. They go through several rounds of mitosis and meiosis, and eventually you end up with spermatozoa. And then if we're thinking about, what I told you before about the rates of some of these disorders, we have billions of pairs of DNA, and these random mutations are going to happen very rarely, right? About 2 in the germline every year. So these are going to be about 1 in 100 million base pairs, right? Way down here. But these disorders are much more common than that, right? So this is about the order we see some of these disorders. So what can explain this discrepancy in these rates, right? And so what we come to realize is that some of these mutations are not necessarily random. Sometimes they could be just randomly distributed in the genome, and it may not have a lot of consequence in terms of proliferation. But potentially, every once in a while, one of these mutations may end up in a gene that's important, and so that mutation may confer some reproductive advantage, some proliferative advantage. And so that may then spread a little bit more. So again, if we think more about spermatogenesis, you can imagine here represented in orange, if this spermatogonia gets a mutation in a proliferation pathway and then can proliferate a little bit more, eventually it's going to outcompete the nearby spermatogonia, and there'll be more of these sperm then that harbor this mutation. And again, the older a man is, he has more mutations, it's more likely to occur in an older man than a younger man. So let's then look at some of the other things that have been associated with advanced paternal age. So birth defects, this is the study of about 5 million individuals. You can see as men get older, this tends to be a slightly higher risk of birth defects with age. There's also cancer risk that's been studied as well, childhood cancers and even adult cancers as well. And the mechanism, again, we've talked about those, increased DNA damage, these de novo point mutations, epigenetic regulation, this so-called selfish spermatogonial selection, where you accumulate these mutations in proliferative pathways. Could be imprinting errors as well. So let's just look at some of the different malignancies that have been studied. So childhood leukemias have been studied. A background rate of about 1 in 25,000 for men over the age of 35. That risk goes down to 1 in 17,000. So it's about a 50% higher risk. CNS tumors, we see that same slight increased risk for older fathers here over the age of 40. Breast cancer, so obviously this is an adult disease, but some large population studies are able to tease this out a little bit. We can see an increased risk from 1 in 8.5 women to 1 in 5.3 when the father was older than 40. Prostate cancer, this is from data from the Framingham Heart Study, where they were able to look over multiple generations. And if the father's over 38, you can see the risk goes up about 70%. And what's also maybe interesting here, you've kind of heard this, is that the definition of older father is not certain. Whether it's you're 38, 40, 45, 50, 55, it tends to vary from study to study. Some hematologic cancers. Here's a non-Hodgkin's lymphoma associated with advanced paternal age, about a 50% higher risk. And then we've heard a lot about neurocognitive disorders. So if you're going to randomly find a mutation somewhere, it's likely to affect the brain in some ways. So autism has been studied, and you can see the rate does increase with older fathers. The rate per 10,000 starts at 7 for the lowest group and goes up to 37 for the highest group in this study. Schizophrenia, also associated with older fathers. Even bipolar disorder, we see a higher risk here. The age cutoff for a man is 55 and see a higher risk. So this is a nice study out of Sweden where they looked at psychiatric and comorbidity. Really interesting. They looked at it in many different models. So we'll have the paternal age here. These are different hazard ratios, and each of these different lines represents a different model that they looked at with different adjustment. But you can see the different things they looked at. So they looked at autism. They looked at attention deficit hyperactivity disorder, psychosis. You see this general same pattern of higher risk with advanced paternal age. Bipolar disorder, suicide, substance abuse. Again, some of these reach statistical significance, some don't, but you see this same general pattern where it seems to be associated generally with advancing paternal age. And then even academic morbidity. Failing grades, you can see higher risk with older fathers. Educational attainment, less than 10 years, so dropping out of school early, also associated with older fathers. And then finally, we think about Down syndrome risk with maternal age, but it also has been associated with paternal age as well. So this field, I think, is very much in its infancy. There's a lot more work that needs to be done to understand this. I also want to be very upfront and say that I think most of the risk that we're talking about is probably going to be, if we're talking about the risk to a child, I think the mother is going to carry a lot more given how important gestation is. But the title of my talk and what I hope to convey is that the father does play a role, contribute about 50% of the DNA. So certainly it's going to be important. And we saw the paternal age, I think, is the best studied. But I think studies are starting to evolve and looking at some other risk factors as well. So I think it behooves us all to pay attention. So thank you. And I want to, again, acknowledge, just like he did, I want to acknowledge Gary and the whole group from the March of Dimes who've helped with this work. Thank you.